Annual Dialysis Conference, presented by the Carl Nolf, MD, Division of Nephrology.
Okay, welcome everybody. I am Kunal Malhotra. I'm a associate professor at St. Louis University, and I'm going to be talking today on PD catheter troubleshooting, drain pain, and infusion pain. I'm honored to present to you, and I'm also thankful for Annual Dialysis Conference and Dr. Khanna and Dr. Rastogi to give us a chance to present this and do this. I would like to start with some introductions on the panel team. So I see Preeti.
Yeah, hello everyone. Thanks so much for joining. My name is Preeti Yoram. I'm a nephrologist at the University of Missouri, Columbia, in the VA hospital here. So really excited to be doing this.
Ankur.
Thank you. I'm Ankur Shah. I'm a nephrologist at Brown University in Providence, Rhode Island. Also a huge home dialysis advocate and excited to be here and appreciate the opportunity from ADC as well. And
Osama.
Hi, everyone. Osama Al-Shami, I'm a nephrologist at the University of Pennsylvania and a home dialysis enthusiast. Happy to be here.
Well, thank you. So we'll jump right into today's topic. I also thank all the attendees who took time after a busy day of work, I'm sure, to be here, whether you're a fellow or attending or a nurse or social worker or dietitian. Thanks for coming. Annual Dialysis Conference has tracks for everybody, so it is very inclusive of all disciplines. So in this learning objective, we'll be able to describe incidence and pathophysiology of drain and infusion pain, recognize common risk factors and etiologies, and how to troubleshoot systematically applying evidence-based practice. So that's the learning objective and goals for today's presentation. I'll start with a case. This is a patient of mine who started peritoneal dialysis early last year, a 50-year-old end-stage renal disease due to diabetic nephropathy on CCPD, reported pain during drain phase of PD exchange for 2 weeks. The pain was described as sharp, cramping, lower abdominal pain occurring predominantly at the end of the drain cycle. It was 7/10 in intensity, sometimes shunt, but sometimes she said like it was deep, kind of like visceral in nature. There was no pain during the infusion part or while the patient was dwelling with the fluid. No fever, chills, nausea, vomiting, or cloudy fluid. She brought one of her bags to the clinic, and that was clear. No recent trauma or constipation, was having regular bowel movement per patient, and had noticed incomplete drains occasionally when we reviewed the logs. Past medical history, as said, diabetes, hypertension, diabetic retinopathy, and peripheral neuropathy. Medications included insulin, lisinopril, amlodipine, Mircera, and sevelamer. And weight, vitals were stable. She was afebrile, abdomen was soft, non-distended. There was no tenderness on palpation. The PD exit site was clean. There was no erythema, no discharge or tenderness. And we tested a PD effluent, and it was clear, and there was no signs or symptoms of peritonitis, and the cell counts are also normal. So this was drain pain, and the next question is why does it matter? It matters because it is very common. Both inflow pain and drain pain, it's very common. It's probably underreported in studies, centers and population, and it varies widely, not just across the center, but also geographically. It has been described, inflow pain has been described in 13 to 33% of patients, while drain pain is reported a little higher at 20 to 36% of PD patients. It can disrupt patients' experience on PD because nobody likes to have that kind of pain. It can trigger or exacerbate symptoms of insomnia, depression, anxiety. Patient will wake up at night, so they will have poor sleep quality, and that will bleed into the day and they will have a poor quality of life because of lack of adequate sleep and weakness and fatigue. And sometimes it can be severe enough to warranty a change in modality. The patient may come and say, I can't deal with this pain. I want to, change to something else. For this is chronologically, this study, which was done by Dr. Blake in 2014, reports the use of tidal peritoneal dialysis amongst ABD patients across Canadian centers. And the reason I'm showing TPD is because the most common cause of using tidal peritonitis, tidal peritoneal dialysis, was drain pain. So it's kind of a surrogate marker of how common drain pain might be. So you can see across different centers, the drain pain was very high, about 86% of cases. This is more recent study published in 2025 this year. And in this study, in a center where they studied 141 patient, inflow pain was reported in 56% and drain pain was reported in 51.8%. Majority of patients had both inflow and drain pain, and then a minority had neither. And if you break down in terms of time from when the PD catheter was placed, most of the pain was reported in the first week. And after that, in 1 month, and subsequently, the incidence had fallen from 50 to 60% down to around 20%. Now, this is data from PDOPS, which studied around 1,600 patients across 121 facilities, 5 countries. They completed a questionnaire where they reported drain pain in the preceding week of when they did the study. And in this study, it was reported in about 28% of patients, and 35% of those 28% reported severe pain. Geographically, it was more prevalent in UK and least in US. And even in US, I think the incidence can vary. So take it with a grain of salt. This is a survey study. It's not like a randomized controlled trial. But some of the things that were fascinating was the PD vintage was significant. You can see this is a forest plot, and if a factor is not touching the line in the center, that means it's significant. And if it's on the right side, then the risk is high. And if it's on the left side, then there is benefit. So if you go down, if it crosses the middle line, then it means that it's not significant. So the first significance is age. People more than 75 years had less incidence of drain pain and infusion pain. Drain pain. And then if you look, PD vintage, having a recently placed catheter was of high significance, and that was supported by the study which I showed in the last slide. And then it was more common in females, so male gender was a benefit. And then if people have polycystic kidney disease, they had more drain pain in this study. The rest of the things were not significant. So coming to inflow pain, there are various factors that have been postulated that could be causing inflow pain. One of them, which is highly cited, is acidic pH of conventional PD solution. It can cause chemical reaction in the peritoneum, which can lead to infusion pain when the PD fluid is flowing in. And you may ask, why not at the end of the treatment, why inflow? And that's because as the PD is going on, the body's mechanism balances the pH. So it's usually present in the first part of the PD. And then there are studies done with neutral pH solution, which if available in your setting, can help in reduction of inflow pain. The second factor is mechanical, the jet effect of the inflowing dialysis fluid when it hits a bowel or other viscera. And that's why many modern PD catheters have a curved design to minimize that effect. And occasionally, the catheter may be placed too low in pelvis, and patient may sense pelvic floor or bladder discomfort with the inflow. And then there could be temperature differences if the bag is not warm enough to patient's body temperature, then they could be feeling that sensation as pain. Coming to drain pain, the factors are more broad. It could be related to technique or patient factors. For example, due to excessive rapid dialysate drainage, peritoneal adhesions, or post-op scarring that may cause focal traction and tethering during outflow, uh, especially in patients who have had peritonitis or who have had prior abdominal surgeries. By the way, this is a myth buster that because patients sometimes people say, oh, the patient has had multiple abdominal surgeries. This won't be a good candidate for PD. That is false. Studies have shown that's not the case. So we should not make that a barrier towards PD candidacy. Coming to other factors, patients with constipation or distended bowel or bladder can cause the catheter to swivel away, that can cause outflow and discomfort. Patients may have abdominal wall or inguinal hernias that may be exacerbated by high intra-abdominal pressure during fluid removal. Again, as we saw, female sex has higher risk because of extra organs in the belly which compete for the space. Similarly, polycystic kidney disease patient, there's more crowding in the abdomen, so that can lead to more pain. And then early PD vintage, as we saw. There could be catheter-related factors. As we saw, coil tip versus a straight tip. A coil tip had a higher odds ratio, as we saw in the PDOP study, about 1.3. If it's placed in deep pelvis, that could be suctioning against the peritoneum. Excessive intraperitoneal length can increase the contact area, which can lead to more pain. Then malposition or migration can exacerbate suction. That can most frequent cause is constipation. Then factors like catheter kinking, omental wrapping, or a fibrin sheath within the catheter can all cause intermittent obstruction in the flow. Coming to modality and prescription factors, APD is associated with higher risk of drain pain, 1.6 times more, and that's because there can be mechanical pulling that's not draining in CAPD, the fluid is draining by gravity, but whereas in CCPD the machine may be actively pulling, causing more suction effect. So that may lead to more pain in APD. Infrequently, the UF target may be bypassed, or there may be overfill events, and that can cause more pain in the abdomen. And in the DOPS, this is kind of like missed factors that only 39% of APD patients who had drain pain use tidal PD, and that I think could be a lost opportunity that we should, if before giving up on PD because of the drain pain, people are not using the tidal prescription adequately to help patients. There are some unknown questions. Is it more common now than in before? Is it because of people are more sensitive to reporting it, or is it because of higher APD use? Is it referred pain on sensitive parietal peritoneum or external bowel? There are various factors, but nobody knows for sure. And is it related to catheter insertion technique? In one of the paper by Dr. Blake, he cited personal communication with Dr. Crabtree, who's a pioneer in the field, who speculated that drain pain may be more likely to occur if the intraperitoneal portion is too long. But again, there's no study which kind of proves it. So now that we have reviewed it, what would be a good diagnostic approach when we have a patient who presents with this? First is to review drain logs. What is the volume? Are you getting the same volume as the fill volume? What is the timing? Is the dwell time increased? And is the pain at the end of the dwell or beginning of the dwell? What is the residual volume that is left behind? Is that adding up and increasing overfill? Ask patients about constipations and examine their belly for any hernias or mechanical obstruction. If all that is normal, consider abdominal imaging. Get a KUB, see where the catheter is placed, and evaluate catheter position by X-ray and its function by fluoroscopy if indicated. Rule out infection. You want to make sure the patient does not have peritonitis or cloudy effluent. Address mechanical factors, constipation and adhesions. Modified drain profile. You can, if the patient is on CAPD, you can increase the bag which is on the floor, so you can raise it to slow down the drainage, and you can increase the depth so that there's more gravity pulling. So you can try that. If they are on CCPD, you can try tidal cycles, in which if patient puts in say 2 liters of fill volume, you program it to remove say 90%. So 10% is left behind. So that is left behind so that it's not sucking out and pulling every last bit of fluid, and patient report less drain pain with tidal cycles. If those things fail, you can try to switch to CAPD and try for gravity drainage trial to see if it's the suction effect of CCPD causing it. If available in your country, trying neutral pH solutions, which is useful as we discussed in infusion pain. If nothing works, and you can do fluoroscopy and then try to see if send to the surgeon or your whoever puts the catheter in your center to see if there is a role of laparoscopy to reposition the catheter, or if there is a omentum wrapping, or if there are adhesions, those needs to be addressed or not. And surgical revision or modality change as a last resort. So, as I said, in PDOP study, only 39% of APD patients with drain pain use tidal PT, which is a big therapeutic intervention, and it should be used more often. So, again, as I said, it leaves some residual volume, so there's less suction. And in that other study by Dr. Blake, their center used 86%. So again, it may be a practice pattern across various centers. So one of the key takeaway from this would be to try more tidal PD in your center if you don't use it. Just a slide upon overfill complication. Overfill is defined when the drain volume is 1.6 times more than fill volume. It can happen in tidal PD, or if there is drain pain and incomplete drains as the fluid accumulates. And it can also happen if there is programming errors. It's rare these days because machines are automatically programmed to empty out everything in tidal prescription after a few exchanges. But there are serious complications, and there are case reports for abdominal compartment syndrome and even fatal outcomes. So just to be aware about this complication. So coming back to our case, I gave my patient some laxative. I gave lactulose, which is my favorite to-go laxative for PD patients. And if that doesn't work, I use Golightly. And patient still had pain, so we got a KUB. And as you can see in the KUB, the catheter was flipped up. Instead of pelvis, it was pushed, and patient had a lot of bowels. So we asked the patient to continue the bowel regimen, take Golightly, and the patient reported that she had good bowel movement and reported relief. We got another KUB, and the catheter had come down a little bit, but still not where we wanted. So we decided to do a peritoneogram. So here I'll show you the video. you see this. So this is the fluoroscopy. The dye is coming in. It's going and it's kind of localized. If you see, it's normally it should diffuse in the abdomen, but here, let me show this again to you. So see, it went a little bit around the catheter, but then it stayed there. It did not diffuse freely into the abdomen. So the interpretation of this would be the initial flow was sluggish, less forceful, instead a wide diffuse spread, and then it pooled near the catheter tip for a few seconds before dispersing. And then it stayed in that limited compartment area. That could be because of fibrin sheath or omental wrapping. And then there was resistance to it, signifying maybe partial obstruction. And so that was the infusion phase. And then we wait for a few minutes, and that's called the drain phase, in which it should just diffuse and disappear. And in this, it was slower than in a normal study. So this suggested that there may be some problem. And I'll show a normal fluoro next. So this is what a normal fluoroscopy. Now this is very hard to find. I had to go through many patients to find a normal study because people usually don't do it if there's nothing wrong. So in this, you see there is rapid inflow, and then the fluid just doesn't collect there. It diffuses into the abdomen. So this is a normal study compared to what my patient had. So after this happened, we sent the patient to for laparoscopy to surgery. They found that PD catheter was coiled in the omentum. They repositioned and fixed the catheter. She came back to the clinic and still complained of some pain during the end of the drain. And at that time, we switched her to tidal PD with 85%, and then her pain disappeared. And for last 7 months, she has been doing well with tidal PD, not complaining of any drain pain. So with this, the key take-home points are that drain pain and infusion pain is very common. It will affect 1/3 of your patients and can impair quality of life. So please ask about that when you see PD patient. The risk factors are female sex, polycystic kidney disease, early vintage, APD used, and coil tip. First-line interventions are constipation relief, adjust the drain speed if you can, tidal PD, and then going down that algorithm that we discussed. And then infusion pain is less common and manageable with flow adjustment if you can, and it usually goes away and is not that big of a problem in my practice. Any questions? I have a few more slides about ADC, but before that, I want to open the floor and see if people have any questions or any comments or what you have seen in your practice.
I think Lisa has a comment in the chat, Kunal.
I don't have the chat on my screen. Let me.
So she said, curious why there is such a low use of tidal PD for drain pain, because I think you showed some data there.
Yeah, that data was from 5 countries across many centers, so it may be center specific. So people, if they know the benefit, they use it. But if there may be like a hesitancy to change prescription or giving up too early, so that's one of the lost opportunity. So that was one of the key takeaway, to make sure that you try tidal PD if patients need it. Okay, now I can see. Any comments?
Please feel free to put any comments or questions in the chat. And I think Casey Collins has a question. Is there any compelling evidence to suggest tidal PD is less effective than traditional APD therapy in removing solutes?
Yes, that's very interesting. Tidal was developed to see if it would improve your clearance. So theory behind developing that was that you are reducing the dwell times. You're leaving some fluid there, so you're not waiting for everything to clear out. So you can do more exchanges. But what happens is the fluid that is left behind is increasing your D0 is increasing the solute concentration. You're not starting fresh from zero, say zero BUN or zero creatinine or zero potassium. There is some potassium which is diluting your fresh fluid coming in. So what's lost in time, what's gained in time, they found they lost in those clear
The gradient.
the gradient initially. So subsequent studies showed that it really doesn't make a big effect on clearance, but they found that people had less drain pain. So now it's primarily used for drain pain and not for clearance. Excellent question. Great question.
Mhm. Yeah, Ankur, do you have any experience with that, or like have you used Tidal for anything else other than drain pain?
I've primarily just used it for drain pain. I don't have a ton of experience using it elsewhere. I also have used it for infusion pain because theoretically, to me, that concept of infusion pain being pH mediated, if you have dialysate that's already there, that acidic dialysate, when it contacts that dialysate, it will hopefully dilute it out. The textbook answer is to inject bicarbonate into that dialysate. I'm not a huge fan of that because I don't like it. Questionably sterile injections ongoing frequently into dialysate. But if a couple amps of bicarb is enough to balance the pH, I don't see why the dialysate that is already there is not enough as well. So I've used it for infusion pain and drain pain. I really loved the study you showed earlier that had the infusion pain and drain pain, and like 50% of the patients had both. So I think that is an area where we mentally compartmentalize these things, but they come together. And just to add one other thing to Lisa's question, which is, I think, a great one of why is there such low use? I think it's kind of the need for talks like this. So you'd need to know the questions to ask and the answers to offer. And I think that there are a lot of places where you're not asking if someone has drain pain. And if you don't know, then you're definitely not going to treat it. And then you still need to know what to do about it. So I think it just goes to the importance of what you're doing today, Kunal.
Yeah. I mean, the big thing, like, I think it's an extension of renalism. Many people, primary care doctors, when they see patient is ESRD, they kind of like don't do the things that they would do for a patient without ESRD. So yeah, and then one more thing about modality. A few years ago, I think it was Dr. Fishbane, or I don't know who it. I think it was him or somebody who's a big proponent of automated PD, which is a fascinating concept. Automated PD is when you program the machine so that the first two cycle are high volume short exchanges, and the last three cycles are low volume longer exchanges. And I don't know if that improves drain pain or not, but it was to maximize clearance. So if you are curious, Google and look up, or PubMed and look up automated PD. It's a very interesting concept to look at.
And I think Ankur made that point of infusing bicarb. So for the fellows in attendance today, that's a board question. So
Yeah,
take note.
Absolutely is.
One thing I'll add, and I'm saying this out loud, Ankur, so that I don't forget, but I think for our study where we're going to be looking at the PD effluent, now I want to check the pH of the effluent between cycles to confirm, right, that the pH does indeed go up.
It's a good idea. I think, I hope it does. Otherwise, my thought process goes out the window.
No, I mean, it's just something that's like interesting to me. I was like, oh, wait, like, that'd be something that's like worth proving.
Yeah.
Has
absolutely.
anyone ever done that? Is there a study? Somebody checked the pH or?
Not that I'm aware of. Not between cycles, and definitely not on cyclers. So I don't know, but I mean, if it's been done, which I'm not aware of, it would have been in CAPD, but APD definitely not.
Yeah, in CAPD, if you ask Dr. Khanna, he's probably when Dr. Khanna and Dr. Tarosky did those studies for PET test, they tested so many things which were not even reported. So in Dr. Khanna's lecture, he used to show those slides where he showed like the curves for like calcium, and they might have studied bicarb, which may not be published or may be published. I don't know, but Dr. Khanna will know.
But Lisa, are you saying that like infusing the bicarb just like, a few times will usually take care of the pain? Is that what you mean? Or I don't know if you're able to unmute and
In the mean,
oh, she cannot unmute.
She should be able to now if you want to try again.
Okay. I think, Lisa, you should be able to talk now.
Can you hear me now?
yes,
Yes.
Lisa.
Okay. No, it's interesting enough. It's like for some reason historically in our program, if we have people who have this excruciating pain, we usually find it like on their second flushes where we actually try to, not the first flush where we're just going in and out quickly, but the second flush is where we're trying to instill, let it sit there, teach them how to change the dressing, do that stuff. And then we use, the bicarbonate, the next couple times, and then it would seem to resolve itself before through training and before the patient would get home, because we had apprehension as you did about having patients instill bicarbonate into the dianeal. I mean, it's a little nerve wracking, right? When it looks at sterile technique and things like that. So.
Yeah, I've had that same experience where I feel like I've seen in two ways. One is exactly that. Your second flush is pretty severe infusion pain. I tend to not really go to the bicarb just yet, although now that you're bringing it up, I might be changing my practice because I do think that's a good idea. I also noticed sometimes both infusion and drain pain starting like a week or two after you get home or kind of in the middle of training when you get home. Your comment that it just disappears is a very valid one. I've noticed that with both infusion and drain pain. I will say the most frequent way that my patient gets off of Tidal is they get hospitalized and the person who's doing their PD did not know they were on Tidal. And so Tidal does not get continued and the pain is gone. So there definitely seems to be an early component to this and a self-resolving component. There are some patients who it just persists and those patients end up sticking with Tidal throughout. I am curious, one of the struggles that I find with Tidal, and I'm wondering if anyone on the call has a solution to this, my patients who use Tidal for drain pain, they still drain to empty with the first and last fill of the night. So they often tell me, okay, it helped me sleep through the night, but I still wake up to sharp pain and I start the night with sharp pain. And so some of those patients will go to manual PD, but I'm curious if others have solutions that have been effective for that kind of last fill, full, or last drain, full fill, last fill, full drain.
I think this is well, not I think, I had this discussion before. I know that this is a programming thing, that the way that I can speak for, let's say, like the Vantive cyclers, they're programmed to, if your patient has like cycles, by default, after their cycle, even if they're on Tidal, it does a complete drain. So if you have 6 cycles, your patient would go through that twice, right? But that's a safety protocol, right, that they placed. I don't think we can bypass that, right? And the idea that they have is that, you're going to have like residual volume. Now, especially, right, if your patient has a last fill, right, then it also doesn't bypass that, because with the last fill, it empties out the peritoneal membrane and it completely empties out all the bags. I don't know if really for APD, if there is a workaround to still leave residual fluid in the patient's belly, unless there's like some change in the programming of the cycler that I'm not privy to.
I have one patient who used to have this, and she used to know a certain position in which she is, the pain will be very mild. So if she was awake, like during getting on the cycle or off it, if she was awake, she would get in that position, and she knew that position will work for her. But at the night, again, they don't have control. And it's right, to prevent that overfill complication and abdominal compartment syndrome, the machines are programmed to do a complete empty out after every 3 cycles or something like that.
Which I guess it's trading one potential problem for another, and safety is, of course, a reasonable thing to emphasize.
I saw a hand up by somebody. I think Amresh had a hand up. Did he ask any question or? No. Okay, so
I don't think I saw anything. Amrish, did you have a question? So, but maybe Osama, with AI and smart technology, there would be a way for tidal, the volume to be better assessed by the machine, and maybe allow us to leave a certain amount of fluid in the future.
Yeah, I mean, it doesn't sound like honestly like an issue that would need even AI, to be honest. You know what I mean? It would just allow for the last cycle to also, like, you can set it to, let's say, expect a UF or like a drain volume of at least, let's say, 90% or 95%, right, of whatever the fill volume was. It's a matter of switching it so that for the last fill, it would have that same expectation, just a percentage of the total. But I'm not sure if this is something, let's say, that a feature or something that they had to run by the FDA in order to be approved for it. I don't know if there's any red tape that kind of necessitated that, or if that's or if that was just like Vantiv's discretion, right, and decision that they made when they made the cycler. That's one thing I'm not sure of.
Yeah. Well, so I would like to just, I was going through the ADC. I'm going to do some little shout outs. There are going to be great topics like, these practical topics at ADC. Some of the topics I related to PD I put here, but there are, imagine there are like 6 times other sessions because there's home hemodialysis session, but there'll be great talks by leaders in the field: Dr. Abra, Dr. Bargman, Dr. Khanna, Eric Wallace, Jenny Shen, Osama, Dr. Shah. So some of the topics that I find interesting, which I'm looking forward to, are listed here. So all our attendees, I encourage them to come and join us in ADC. The registration is open, and you can go to the website. The next talk here will be by Preeti, and you are speaking about role of multidisciplinary team in helping patients succeed at home dialysis. So great practical talk. Everybody is invited to please come and join again, and tell your friends and colleagues about it so that they can also come and join. For abstract and case summaries, they are open. We have a fellows forum which is unique. It's 6 to 8 fellows are chosen to do a case presentation on the podium, which is great for presenting to your peers. And there's usually a prize for the winner. It's judged, and there's a keynote speaker at that event. So please come and submit. And if you submit, there is usually the registration. If your abstract is accepted, your registration and other there's a grant to support that, and I think the grant will be there this year as well. Preeti, you want to add anything?
I think you summarized it all well. So yeah, this is a great opportunity, and this is a conference that is a very clinically oriented conference, great networking event. So if you are especially a junior faculty that you're coming into the field of nephrology, this is great. I've always made a lot of connections ever since I started as a junior attending. And those have gone on to other things. So really a great opportunity to learn from your peers and also make those connections. You have any other questions, comments in the chat? Anyone? I think people can unmute 2. Kelly, can people unmute or?
Yeah, if
Okay.
anyone who wants to speak up, they can just unmute their microphone. We have everybody set up so they're unmuted on our side. So.
All right.
Okay, well, thank you everybody for being here today. Please come back next month. This was for 45 minutes. We give you back three extra minutes to enjoy and get back to your families. Thank you for joining.